Thank you, and good morning. Good morning, everyone. Thank you for attending today's meeting of the Adult Care and Public Health Scrutiny Committee. I am Councillor Jimmy Brooks, the chair of the committee. This group plays a key role in helping to shape and improve vital services across Lincolnshire. I'd like us all to be focused, practical approach, working together to add real value through our scrutiny. I'm looking forward to a very productive year working with you all. Before we begin, there are some standard announcements. If we hear the fire alarm, we need to leave the council chamber through the rear door, which is that one I'm assuming, into reception and assemble in the car park at the front of the building and await further instructions. In addition to welcoming all members of the committee, I would like to welcome Councillor Steve Clegg, Executive Councillor of Adult Care and Health, Martin Samuels, Executive Director of Adult Care and Community Wellbeing. Other participants will be introduced when we reach their item or when they first speak. This meeting is being streamed via the County Council's website, and all your comments will remain accessible online after the meeting. With this in mind, I would like to welcome members of the public and press who are watching. Just a couple of housekeeping announcements before we begin the agenda. Can I remind everyone to ensure their mobile phones, laptops and iPads are now on silent. Requests to speak will be collated at the top table. If you wish to speak, can you please raise your hand and we will make a note. We will try to ensure everybody can ask questions and make contributions. Therefore, I would appreciate contributions are to the point, and also ask that you indicate early if you wish to speak. Thank you for that. We'll move on to agenda item 1, apologies for absence and replacement members.
Thank you, Chairman. We have apologies from Councillors Litchfield, Cullen, Lee, Cook, Woolley and King, and we have Councillor Rowe replacing Councillor Cook and Councillor Bean replacing Councillor King for this meeting only.
Thank you. Agenda item 2, declarations of interest. Members of the committee are reminded that you only need to declare the relevant interest which have not been declared on their declarations of peculiar interest form. Do any members wish to declare interest? No. Thank you very much. Agenda item 3, minutes 26th of February 2025. To confirm as correct record of the minutes of the meeting on 26th of February 2025. The minutes are found on pages 5 to 10 of the agenda pack. Just before we get onto that, I request that the correction of linker on page, I think it's page 9, be corrected to LINCA. Have we all had a chance to read the minutes? And are we all happy they are correct? Yeah, could we have a proposer for those, please? Could be himself. I'll propose we accept those. Do we have a seconder at all? Thank you. And a vote of all in favour? Thank you. Unanimous. Is there any abstentions or against? No. Brilliant. Thank you. Agenda item 4. Just bear with me, I've lost my page. As the chairman, I have no announcements for this item. Can I ask the Executive Councillor, Councillor Steve Clegg, if he has any announcements, please?
Thank you, Chairman. No announcement as such, but I'd just like to introduce myself, Councillor Steve Clegg, Executive Councillor for Adult Care and Public Health. And Chairman, as you know, we spoke briefly last week about how we can work constructively together to ensure that scrutiny challenges the decision-making process and that we continue to improve the delivery of these vital services of adult care and public health. And I just want to emphasize that I want to work closely with you. And I know it's a cliche. I'd like this council to be considered as my critical friend You don't necessarily have to be my friend, but by all means be critical. I think that's a healthy process, and I look forward to working with all of you in the future. And I would stress that obviously there are these formal meetings, but feel free if you wish to contact me outside of this forum. If you've got particular issues, concerns that you'd like me to consider, then I'd be happy to do so. Thank you.
Thank you, Councillor Clegg. Can I ask the Executive Director, Martin Samuels, if he has any announcements, please?
Thank you, Chair. So just one brief announcement. So members of the committee may be aware that the Care Quality Commission is as the regulator of adult social care and health services. One of the things that they've been doing over the last couple of years has been inspecting local authority commissioning functions. This is the first time that's been done in well over a decade. Lincolnshire County Council was the very first pilot in the country to go through that process about 2 years ago. At the time, we had been given to understand that that would effectively be our involvement in the inspection process, and that the CQC would not come back to us until they had finished the country, and then when they did a second wave, then we would be involved in that wave. We have recently been informed that in fact they've decided that the pilots that they undertook here and in 4 other authorities will not count as part of the first wave, and therefore that we will be inspected as part of that first round of inspection. That first round is due to be completed by the end of this current financial year. It's a 6-month process. Therefore, we are expecting that I will get the call from the CQC. They do it on fixed dates, so there's a date early in July and there's a date early in September for the remaining authorities that haven't been called yet. So we are expecting that I will get a call on one or other of those dates, and then we will enter the 6-month process and will then be inspected during the course of that, and then a report published at the end of that process. So that's a bit of a change from what the previous committee had been told. It's new information for us. I'll say more about the Care Quality Commission and their approach in my presentation shortly, but I thought it'd be helpful just, Chair, if to give that as a sort of brief update.
Thank you, Martin. Agenda item 5, Introduction to Adult Care and Community Wellbeing, verbal report by Martin Samuels. If there is any specific questions or concerns regarding this report that you'd like to explore further, please let us know after Martin Samuels has spoken. Thank you.
Thank you, Chair. So hopefully the slides are, there we go, the slides appeared on the screen there. So what I'm intending to do is to just give a brief outline of adult social care and public health. I'm drawing out some of what was provided in the recent member induction for adult social care, but what I'm particularly intending to do is to focus in on some of the issues that may be of interest or relevance for this committee that you may want to pick up in future meetings. So if we go on to the next slide. So clearly, you know Lincolnshire. You are elected representatives from Lincolnshire, so you don't need to be told that it's the 4th largest county in the country. The point from an adult social care and public health perspective is its rurality, and in particular the very extensive length of coastline. And those are significant issues for us in the delivery of social care. In a previous authority I worked, I had a lot of home care rounds where the staff could deliver that round walking. They could walk from one person to the next, and therefore we didn't have to build in much travel time. They could have a very compact area. That's very rarely possible in Lincolnshire, and that has a big impact on the way in which we're able to provide care. And that connected with the low population density and often the issues about coastal economics mean that Lincolnshire can be really challenging to provide care for from an adult social care perspective. Again, you'll be well familiar of the population of the county, just over 750,000 people. It is sometimes said that if you want to see what the rest of the country will look like in 10 or 15 years' time from a demographic perspective, Lincolnshire is the place you need to look. we have a significantly larger proportion of the population are aged over 65. Recognise that 65 is starting to be a bit of an outdated age. Sort of 67 might be more appropriate now, but that's where nationally we stick to at the moment. So 23% of the population over the age of 65. That over 65 population expected to increase very significantly over the next 20 years or so. And in particular, the over 85 population expected near enough to double. From a social care perspective, those numbers are really important because it means that we will have significantly more people who will require care. It's pretty much a rule of thumb that if you're over the age of 85, you will need some form of care. There are, of course, exceptions, but near enough everyone over the age of 85 is in the care system. If we have twice as many people in that age cohort, then that will be a significant increase in demand. But as we have a smaller proportion of the population are of working age, we'll have fewer people available to provide that care. And that's difficult in a rural area anyway. So we face a real challenge, significant expected increases in demand and significant pressure on the workforce to deliver, to meet that demand. And just to the point about, although I've emphasised that people over the age of 85 are almost certain to be in the care system, we are seeing a lot of people over the age of 65 who struggle with the activities of everyday life, have often multiple long-term conditions, and we see significant disparities in health quality and life expectancy in different parts of the county related to areas of deprivation. So it's very unevenly spread across the county. If we move to the next slide, adult social care is a highly regulated, highly legislatively based service. There's a lot of legislation there. I'm not going to go through that all in detail, but just to note that to a very large extent, what Lincolnshire County Council as an upper tier authority is required to do in terms of adult social care is set out in legislation, both primary legislation as I've listed here, and the extensive regulations and statutory guidance issued by the Department of Health and Social Care. And it's worth noting that whereas legislation for the NHS tends to focus on how the NHS is managed, legislation for social care tends to set out what it is we are required to do. So, for example, the process of assessment is set out in legislation, the threshold for care, the rules for charging for that care, the approaches to safeguarding are all set out in legislation, and there's very little scope for modification by the local authority. The two acts related to mental health, the Mental Capacity Act and the Mental Health Act, I would particularly flag. To a very large extent now, people living in care homes are, to a large extent, people who lack mental capacity. And so we are effectively caring for people who are unable to make an informed decision on their own. And so our approaches to working with those individuals, making sure that they have as much freedom and as much choice and control over their lives as they possibly can while remaining safe. It's a very tricky balance, and it's very important that we follow the legislation, and there is comprehensive legislation there. And picking up that point about that such a large proportion of people in residential care lack capacity, one of you'll come across the Cheshire West judgment, a very, very important legal judgment in this area made just over a decade ago. One of the points that the judge made there was that a gilded cage is still a cage, and we are very strictly controlled in terms of how much of a cage we put people in, and it has to be for their own safety. And it was a point that was very much brought home to me when I first became a director about a decade ago, that adult social care is probably holding more people against their will than the prison service is. Obviously in a very different context, but it puts it in context, and that we are every day making decisions to restrict people's liberty for their own good, but it's very much, it's something for us to be very much aware of. And then the other act in terms of mental health, recognising that increasingly people come into the care system because of issues with their mental health. We have a significant pressure in terms of our working age mental health services. And so this is more and more we're dealing with people who have mental illness rather than necessarily physical disability, though that's still obviously a major part of our work. But the key point is there's a very extensive and generally very strong and effective legislative basis for adult social care in particular. So if you move to the next slide. People often struggle a bit to know what adult social care is. In a sense, we all have a fairly clear idea of what the NHS is. We know about hospitals. We've watched Casualty on TV. We've seen many a drama or documentary that's based in hospitals. We know what GPs do. We know what community hospitals are. All of us will have had and will continue to have fairly regular contact with the NHS, and therefore we have a pretty clear idea of those services. Most people will never have engagement with adult social care, and often, no one grows up saying, "I'm looking forward to being in a care home when I'm older," and so many people will have very limited engagement with adult social care, and it may come as a surprise quite what it is when they do have contact with us. It is easy to think that adult social care is either the service that gets you out of hospital, which is a little bit simplistic, or to think that it's a service that just makes sure that people are washed, dressed and fed. In fact, adult social care is so much more than that, and there's a long list of duties and functions there. We have, and all of these are based on our Care Act duties. So we have a responsibility about preventing need arising in the first place. As I said, no one grows up saying, "I'm really looking forward to being in a care home when I'm old." One of our statutory roles, is to work with communities to enable people to live a good life that either avoids the need for social care or delays it until way into their older age. That we have responsibilities about assessing need and delivering that need, ensuring that people have as much choice and control over that care as they possibly can. We have a responsibility about safeguarding people who are at risk of abuse and neglect. That's not a general duty. The general duty of protecting people obviously falls to the police. We have a particular duty in terms of safeguarding of people who may be vulnerable, so people who are in the care system. We have a responsibility to work with our partners. We have a responsibility to work especially with our partners in the independent sector. So to an almost universal extent, adult social care is delivered by independent organisations, whether they are for-profit or not-for-profit. People are often surprised to hear that although we always think of the NHS as the biggest organisation in the world, more people work in adult social care than work for the NHS. So there are some 21,000 people in Lincolnshire who work in adult social care. Only about 1,000 of them work for the council. The vast majority, and that is typical across the country, the council is not a provider of care directly. All care homes, all home care, all reablement services are provided by external organisations who are commissioned by the council, and therefore we have a significant role in shaping that market. Worth noting also that adult social care is a means-tested service and always has been, and therefore a very substantial proportion of care is bought by people for themselves, and where it is organised by the council, following the statutory guidance that we are required to follow, we assess people's means and we generate many millions of pounds of income to cover the cost of people's care. And it's worth noting just how far that goes. So someone who is living on benefits They will often receive disability benefits because of their condition, and if they're receiving care, a very substantial proportion of that disability benefit will be taken by the council to pay for that care. So it's a significant part of our business. But finally, just on this slide, issues around promoting well-being, which obviously fits with preventing needs. We have a statutory duty. Section 1 of the Care Act actually says it's our duty to promote the well-being of the population. We have a particular role around supporting carers. There are some 70,000 people in the county who provide unpaid care. It is an incredibly important function. It makes a massive difference to the quality of life of people who receive that care. Unfortunately, it can also make a massive negative impact on the people who are providing that care. Unpaid carers can find life very difficult. We have a major role in supporting them. And then lastly, about advocacy, as I said, a substantial proportion of the people that we work with are unable to make informed decisions. We have a role to advocate on their behalf to make sure that things are as good for them and that their views are taken into account as much as they possibly can be. So if you move to the next slide. So if we pick up about the Care Quality Commission, as I say, the national regulator, it is illegal to provide health or social care in this country and not be registered with the Care Quality Commission and then be regulated by them. So all of our providers are regulated by the CQC, and the CQC, as of 2 years ago, has now been regulating and inspecting council commissioning functions. As I say, that had been abolished after the 2010 election. It was brought back in 2023 and is now part of the system. I've set out briefly what the approach is there. It's a 6-month process, very different from the inspection process that Ofsted use when they inspect the local authority. So when Ofsted inspect a local authority, the Director of Children's Services, so Heather Sandy for Lincolnshire, will receive a call. A week later, Ofsted will be on site with a team. They'll be on site for 2 weeks. At the point where they leave, they will give informal feedback and a provisional rating, and that is then formalised over the next couple of weeks. CQC, it's a 6-month process. It will probably be 3, possibly even 4 months from the point where I get the call before staff arrive on site. They will give no feedback while they are with us. We will get the report towards the end of that period. It's deliberately and consciously on the part of the CQC a very different process. We will see how it goes, but as I say, when we went through the pilot process 2 years ago, we got a very good rating. That rating is currently still, I think I'm right in saying, the 3rd equal best in the country. About 40 councils have been completed and published so far, but it is a very different inspection process that they're using now compared to what they piloted with us 2 years ago. So if we move on to the next slide, I'm now going to talk a little bit about public health, which is sort of the other half of this committee's responsibility. So public health, the science and art of preventing disease, prolonging life, promoting health through the organised efforts of society. And I think one of the things that really I would underline is whereas the medical model is about looking at the individual in front of you and trying to use interventions to support that individual, the public health model is to look at the whole population and see what can be done that will make the biggest impact for that whole population. And the two can sometimes lead to very different conclusions. If we move on to the next slide, again, the public health has a significant body of legislation that it sits upon, but and the Health and Care Act of 2012 is the key piece of legislation that moved public health from the NHS, where it had sat since 1974. Public health for many, many, many years was a local government function. It was moved into the NHS in 1974. It then was moved back to local government after the Health and Care Act 2012. along with a ring-fenced grant, which currently sits at about £39 million. And that move recognised the fact that the things that make a difference to people's health are not what the NHS does. That healthcare is perhaps at most about 20% of how long someone lives and the quality of their life. The other 80% is about education, employment, housing, environment, community connections. Those are the things that make a difference to someone's quality of life and therefore their health. And all of those are far more within the remit of local government than they are of the NHS. So it was very, in my view, very sensibly transferred across back to local government where it had come from. We have a range of functions and responsibilities, which we can go into later, but there's also a key local government role here. So I'm sure members of the committee are aware of the Health and Wellbeing Board. The 2012 Act set up a requirement that every upper tier local authority in the country, all 153 of us, are required to have as a subcommittee a Health and Wellbeing Board, which must bring together the local authority social care and public health functions and the local NHS, along with relevant other organisations and views, in order to consider the well-being of that local population. And obviously public health plays a key role in that. So you move on to the next slide. The three domains, if we build up the slide, I realise it's got three builds to it. If you just do all three aspects of public health. Health improvement, so working to address those issues of wider well-being. Health inequalities are a significant issue. Education, housing, employment, family, lifestyles, and then specific disease factors, as I've sort of touched on. So that's a major part of public health. Second part is the public protection side. I'm sure none of us will forget COVID, much as we might wish to. Obviously, that was an area where public health steps to the fore, but the role is much wider. So obviously, preparation for the next pandemic, and unfortunately, there will be another pandemic at some point. But hopefully, that date is many years off, in no small part because of the activities of public health, and looking at a wide range of other areas that could have an impact on people's health. One element worth noting is one of the successes that we've had in Lincolnshire is that the health protection team has health protection staff connected, linked to every care home in the county. Infection prevention and control is incredibly important in a care home situation. These are people inevitably in poor health living together, and therefore the risk of infectious disease taking hold in care home is always there. The public health protection team play a really critical role in helping care homes to manage and avoid that risk. And then the final aspect of this is about health care. There are a number of services which are directly commissioned by the public health team, and there's also a really critical role that the public health team has in supporting the NHS in using the expertise that they have to make sure that healthcare is directed in the most effective way. So move on to the next slide. Prevention is one of those things that I'm going to come back to, and is a sort of centerpiece of everything that we do. The quote there from Benjamin Franklin about an ounce of prevention being worth a pound of cure. We know it, but it is very often very difficult to put that into practice, because often the impact of preventative work may not be seen for many years. Someone getting a really good education at school that enables them to get a good job is likely to put years onto their healthy life expectancy. but you may not see that until they're in their 60s and 70s. So 50 years later, we'll be seeing the benefit of effective preventative work. So it can be quite tricky to connect both in time frame, because we have a tendency to be quite short term in our budgetary view, but also the lines of causality can sometimes be quite tricky to identify. Nonetheless, prevention is enormously important, and we talk about primary, secondary and tertiary prevention in terms of ensuring there's a generally healthy population, working with people who are at risk of developing a condition and screening people. Obviously, you'll be, members of the committee, be aware of a range of national screening programs. Public health plays a key role in those, and then even people who have already developed a health condition, there is a great deal that can be done to help them manage those conditions, to help them recover from crises, that can enable people to have a really good quality of life and thereby reduce their need for care. And not only is that really good for people, but the more that we can reduce the need for care, of course, the less care the council has to provide and pay for. So, talking about quantities and care, let's move on to the next slide. Some headline numbers in terms of the number of people that we support from a social care perspective. I think the key thing is to note how small those numbers are. So the total number of people who are in long-term support across the counties, funded by the County Council, just over 11,000 people. I say that's out of a population of 770,000 or so. So we are about 1.5% of the population, maybe 2% of the adult population is supported in the care sector. Worth noting that adult social care is the largest single area of expenditure for the council, and takes up more than a third of the council's entire expenditure, and that's spent on about 2% of the adult population. As I say, we split the people we support by age cohort, so 18 to 64 working age adults, and then 65 plus older people. You'll see there's about twice as many older people in the system as there are working age adults. As we'll see on a slide, in fact the next slide, we spend about the same. Sorry, it will be on the next slide, but we won't move on just yet. We spend about the same on working age adults in total as we do on older people. Essentially, working age adults individually, if they're in the care system, cost about twice as much as the average working age adult in the care system costs about twice as much as the average older person, and that's due to the complexity of their needs. But working age adults who are in the care system, 3/4 of them we are able to support in the community, only about 1/4 in residential care, whereas for older people aged 65 plus, it's about 50-50. So if we now do move on to the next slide, apologies, lots of numbers there and quite small font. This is two ways of presenting the same data. So you'll see that the two total lines are the same. So the first point is that the spend, and this is for the directorate as a whole, the vast majority is adult social care and public health. There, you'll see the public protection line, which includes elements of community safety outside the remit of this committee, is only 6 or 7 million. So the vast majority is adult social care and public health. Just over £200 million spent last year. We came in just under budget. I think that works out as we came in under budget by about 0.75% of the budget, so very nearly on the money. As I said, the split between working age adults and older people is pretty nearly 50-50. as you can see from those two top lines, there's some working age adults in the top line, and then the second line is all working age adults. And then you can see that although only a quarter of the people who are working age adults and about half the people who are older people are in residential care, that is by far the largest area of spend for us. So we spent £135 million on residential care last year. Worth noting, Lincolnshire has some of the lowest fee rates in the country, and in a minute when I come onto some slides, I've got some comparative data. So we are one of the lowest spenders in terms of our fee rates, and yet residential care by far the largest single figure. Again, to put that in context, that figure for residential care spend is about the same as the whole of the Children's Services Directorate. Obviously that excludes schools, which have a ring-fence budget, but essentially we spend on residential care alone the same amount as we spend on the whole of children's social care and the relevant bits of education. But it gives you a sense of the complexity and range of what we do. It also helpfully brings out that those figures are net figures, so the net expenditure just over £200 million. You'll notice there are two very large minus figures. So there's the Public Health Grant and the Better Care Fund, which is grant money that we receive either directly from the government or from via the NHS. So the Directorate actually spends in the region of £330–340 million a year. That's our gross spend. So a very, very substantial amount of money. So if we do move to the next slide, that's the figure. These are the figures for the medium-term financial plan over the next couple of years. So you'll see that our budget, which last year was 210 million, in the current year, it's the middle bold line. In the current year, has risen to 224, and it is forecast to increase by a further £20 million or so every year through the planning process. And you'll see that the vast majority of that comes from the combination of the national living wage and inflation, and from increases in demand, which is a combination of demography. There are more people and there are more people with disabilities, and complexity that our colleagues in the NHS are increasingly successful in keeping people alive with significant health issues. Frankly, people who previously would have died, but their care needs end up being very, very complex, and therefore the average cost of someone is increasing quite rapidly, not just because of inflation and the living wage, but just people need more care, the packages there. And worth noting that the national living wage is a key driver for us rather than inflation. So governments have been increasing the national living wage by about 6% a year for a number of years. We base our fee rate models on staff being paid at the national living wage. So they are paid the lowest that it is legally allowable to pay them, and we therefore have to build that into our fee rate. So if the government increases the living wage by 6 or 7%, effectively we have to increase fee rates by that amount as well, because there's nowhere else that providers can go. So I say the increase in the budget, about £20 million a year. To put that in context, that is slightly more than a 5% increase on council tax, and that is essentially just allowing us to stay still dealing with inflation and the number of people in the system. So if we move on, then I've mentioned that we have some of the lowest fee rates in the country. So this is comparative data, and there's an organisation, so my professional organisation, the Association of Directors of Adult Social Services, ADAS, we do work every year with every authority in the country looking at the use of resources, the use of spend. So I've got a couple of slides here. The purple line across the middle is the average for local authorities in England for the spend per head of population over the age of 65. So the line is the England average, the purple block on the right-hand side is the East Midlands average, and then the 10 authorities in the region are listed alphabetically. So Lincolnshire comes out in the middle, and you'll see that in fact not only was Lincolnshire the lowest spender per head of population aged over 65 in 2023, we were in fact the lowest in the whole country in terms of our spend per head. Again, you know, it's very small at the bottom, but the England average was £1,092 per head. We spent £696 per head. So very, you know, as I said, nowhere else in the country spent less than Lincolnshire did. If we do then the next slide, which is the same slide but for working age adults, exactly the same format, you'll see that Lincolnshire was the second lowest spender per head of population in the region, and we are, I think, in the bottom 10% nationally. So, and to an extent, that is that there are fewer people that we have accepted into the care system. When we can't ration, the thresholds for accessing social care are set nationally. Local authorities have the right to make it easier to get adult social care. They do not have the right to make it more difficult. Our low spend is partly a combination of effective prevention work through the public health team and the very low fee rates that we pay. So if we move on then to the next slide, I've almost finished, so hopefully I haven't tired the patience of the committee too much. We are recognising the pressures in adult social care, you know, that £20 million a year additional funding requirement. We absolutely recognise the impact that has on the rest of the council, and I should say that £20 million a year is achieved. That is only achieved on the basis of very significant activity to control pressures and demands. We've established a comprehensive transformation programme, has a range of strands of activity within it, led by you know, each of the members of my senior team. Again, I'm not going to go into detail now, but it's a comprehensive programme. And then if we move to the next slide, then we've been expressing this through a new target operating model. Again, I won't go through this in any detail. The point is that it is very much focused on enabling people to lead a healthy life in their own communities, and thereby minimising and delaying their need for care, and then where care needs do start to appear, wherever possible, to point people in the direction of things they can do for themselves or resources that they can draw from in their local communities. So again, not at cost to the council. And then the idea of there being some targeted services that can work with people where they are developing their care needs. But if we do effective work with them, then we can minimise those needs so that they don't need formal care either at all or for some time. And only when we've gone through that whole process, and I should say, you know, making maximum use of technology as well to support people, only at that point do we say, okay, right, let's look at providing formal care, sending someone into their home to provide care, or moving them to a residential care home. So the whole philosophy is based on enabling people to lead the best life they possibly can, determined and defined as they determine it, but doing that always in preference to providing formal care. And that is the way that we've identified that we can enable Lincolnshire people to have the best possible quality of life, which is obviously the number one goal, but also then to enable us to live within the resources that are available to us from the local authority. And so if you move on then to the final slide, then I pulled out some of the things that the the predecessor to this committee looked at over its incarnation, just really to highlight some of the things that this committee may either be asked to look at. There may be issues where Councillor Clegg may be about to make a decision, or issues where we are working on things, and where a view and a perspective from the committee would be really helpful. Clearly there'll be things that you as members of the committee identify and come forward with, but things that that were looked at by the previous committee. Extra care housing, this is a really important part of the system to help people who have care needs, where those care needs are greater than they're able to then live independently on at home, but they're not so great that they need to go into a care home. We have several extra care schemes in the pipeline. I think it's fair to say that we have identified that we have a very significant gap in the amount of extra care available in the county. There are several hundred people who are currently in care homes who, had we had extra care available at the point where those needs developed, we might have been able to enable them to stay living independently, and that's a better outcome for them, and extra care is dramatically cheaper than residential care. The committee talked about active recovery beds, a very successful scheme to work with people who have had a crisis. Generally, people who've had a crisis and had to go into hospital, been discharged, they no longer need the care that a hospital can provide, but they're too poorly to go home, and they often, we often say being in hospital is a really dangerous place, because although hospital will mend the disease, every day that you're in hospital you are losing the ability to look after yourself, to do the activities of everyday living. You know, being in bed for a day, particularly for an older person, is incredibly bad for them. We want to get them out as quickly as possible. The active recovery beds are a scheme that allows us to provide intensive reablement support to people who've gone through a crisis, can be brought back to either where they were before the crisis or to a level near to it, and then are able to go home with a much smaller level of care than they would otherwise have done. The carers service, I've talked about how important carers are. We have a service that supports them. That's been an area of considerable interest to the committee previously. The integrated lifestyle service that goes under the branding of 1U Lincolnshire, our integrated physical activity, obesity and smoking cessation service. It's been externally evaluated to say that for every £1 that the council spends on that, there is £12 of public good generated by that service. A major preventative service. Lots happening, lots of issues that the committee has been interested in before, may well be interested in the future. The Director of Public Health is by statute required to produce an annual report. You may have seen the recent report, which was about integration across the health and care system. His previous report before that was about the position of older people in Lincolnshire. Fascinating reads, really important places that bring together the data and the issues. Again, the committee previously has found those very useful and have stimulated debate. Obviously, the budgets and the budget outturns will be of considerable interest to the committee, given just how much of the council's money we spend, and then the issue of fee rates for care homes and home care. Again, every year these are issues that will tend to appear on the work plan, and so maybe things that you want to consider. So I'm aware I've probably spoken for more than I intended, but hopefully I've provided a sort of an outline, and I'm aware that there are opportunities in due course to have more of a conversation about this. Sorry, Chair.
Thank you, Martin. Would it be possible to send all the slides out to all members after the meeting, if possible, please? I think that would be quite beneficial. Also, after the meeting, would it be possible to have like a follow-up session for members who are interested to learn more? Thank you very much.
Very happy to do so.
Thank you very much. Also, just to let you know, we also have present Rich Hand Ramruttan is online joining us, so welcome. Do we have any questions or Councillor Rowe?
Thank you, Mr. Chairman. Martin, we obviously have a good adult service. It's rated as good, and it's done on quite a low budget. So I'm assuming there's not a lot of fat in there. How concerned are you that after the next inspection, there might be extra costs that we have to do to meet requirements of the CQC? And is there any available finance within the current budget to meet any further requirements coming out of that inspection?
Thank you. That's a very good question. So I would hope that Lincolnshire County Council will maintain the rating when we go through the what I'm going to call the proper formal inspection compared to the pilot. I'm hopeful that we will maintain the rating that was provisionally given to us 2 years ago. There were a number of areas that were identified by the CQC 2 years ago that have required action are continuing to be addressed. In general, those require management action and the redirection of activity rather than the creation of new services or the incurring additional costs. So I wouldn't expect that the CQC would, in their report, would say, well, you've got a real problem in this service or that service or the other service, and that to address that I would need to be going back to the executive and saying, look, I need an extra million, an extra 5 million, whatever. Clearly, there isn't much fat in the council's budget, and we are in a zero-sum game. So, and if I did require more, then that would have to come from other directorates. Clearly, that is not a position that I want to be in, and I will do absolutely everything with my team to address any issues that come out within the budget that has already been set. But as I say, my expectation is that the things that the CQC identify will require us to act from a managerial perspective to redirect and refocus what we're doing, as opposed to doing things that will incur significant additional cost.
Thank you, Councillor Rowe. Thank you, Martin. Is there any more questions? No, I've just got a question. Sorry. Councillor Young, sorry, I didn't see that.
Thank you very much for that. Martin, in terms of in terms of future work plan, in terms of eligibility, I think that'd be useful in terms of giving the committee some insight in terms of eligibility, because it's quite clear in terms of the process. One thing which from a I suppose in terms of a district perspective is that I think the stats is around about only 10% of people who request support actually go through in terms of receiving a long-term support package, which then kind of suggests that 90% of people are either ineligible or signposted to other services. And clearly they've got a need of some type, but they don't meet eligibility. And although it doesn't fit into the remit of this service, I think that preventative type services is important, and having knowledge around what services are available and where they're located geographically across the county would be useful in terms of understanding in terms of that, because genuine demand is high. I don't think people, I think people genuinely request support. They've got a need of some sort of social support, and it impacts on all types of services like GP services, etc. The more knowledge I think we've got as members in terms of actually where these preventative or low-level type services are would be useful. I don't know if you've any thoughts on that.
So a couple of, so in a sense, I think I'm going to read a couple of questions into what you just said. So the first, we would be very happy to bring an item to the committee in due course about this is the process that we go through. You know, this is how we do an assessment. This is the guidance that we have that we're required to follow. This is the way that it's done, and bring some of the data in that. And I can see Andrea, who has responsibility for much of that service, is scribbling notes already. You know, this is her area of expertise. So very, very happy to do that, and yeah, at a point that would be useful for the committee. The second point that you raise about what happens to the and you are absolutely right, it is the very large majority of people who approach the council for in a sense, they approach us saying, I'm struggling, I think I need adult social care. The very large majority of people in that situation do not then go on to receive adult social care. And I would regard that as a good thing, on the basis that if we are able to point people to resources that they themselves can make use of, or that are available in their community without the council having to be involved or pay for it, and of course adult social care is a means-tested service. So if we draw people into the service too quickly, they'll be paying for it. There is also evidence that the sooner someone goes into the care system, actually that can have a negative impact on their long-term health and well-being outcomes. That actually being, you know, if you don't need to be in a care home, don't go to a care home. It will not do you any good. And so from all of those reasons, we're very keen to support people to find alternative options. And just as an example, we often find that people are quite concerned about relatives who are elderly relatives who are struggling to look after themselves at home. And one of the things that we're able to do now is to say, well, there is a significant volume of consumer electronics available. You know, I mean, a lot of us have those video doorbells and the like. That kind of technology can be bought by people themselves at quite low cost and installed quite easily and simply in the elderly relative's home and set up so that, you know, if their relative doesn't switch on the kettle before lunchtime, it'll send an alert to the family member. So that kind of thing is pretty straightforward, and that has real benefits for the individual, because, you know, we're not sending strangers into their home. They're able to maintain their control over their life, but the family are able to support them, and it doesn't cost very much, and, you know, it's not being charged by us. So again, we'd be very happy at a point that was convenient to the committee to bring a report that talked about some of the preventative work and what we do with people. So in a sense, we can bring two things. One, of someone gets through to the point where we need to make a formal assessment. How do we do that? What happens with that? But also a separate item looking at, well, what, you know, from the point someone contacts us, and of course contacting us could be looking at our website. We have an extensive website that brings together the opportunities people have for capacity in the community. We can bring a report on that. Very happy to do that.
Thank you, Councillor Young. Thank you, Martin, for that. Yeah, I'm really looking forward to that report. That's fantastic. Thank you. Any more questions? I just have a quick question, Martin. It's regarding the lowest spend in Lincolnshire per head and the second lowest. I just want to check that we're basically providing enough service and the quality, because obviously we see QC coming in. I just want to make sure we're on the same par, because obviously you look at some others are spending double and we're spending half. Thank you.
So let's start with with sufficiency. So there are a significant number of care home beds in the county that are not being used. So what that means is that we are able to place, and it's the position is a little bit different for working age adults, but for older people in particular, there is no difficulty in us finding placements for older people who need care in a residential home. We have pressures in the home care market, but again, we are able to find care for individuals. We don't have long waiting lists of people stuck in hospital waiting to be discharged. There are, without question, significant pressures on the workforce. The adult social care workforce nationally has the highest rate of turnover of any sector in the entire economy. On average, between a quarter and a third of people who work in social care will change employer in the average year. We face fierce competition for staff from hospitality and retail sectors. They'll pay the same, but often have better, broader terms and conditions. So getting the staff is a real challenge, but we are able to get, if people need care, we can get it for them. In terms of the quality of that care, obviously all of that care delivery is regulated by the Care Quality Commission. Couple of points there. The average ratings of providers in Lincolnshire is below the England average. So providers are finding it difficult to maintain the level of quality that is expected and required. I can't deny that there is a relationship between the quality of care that is provided and the level of fees. It's not a straightforward causal, it's not a linear relationship, but I think it is true that the very low, comparatively low rate of fees that we are able to pay in Lincolnshire does make it more difficult for providers to maintain a very high level of quality. I should say that the Care Quality Commission has had, and this is very publicly documented, has had major issues in terms of its delivery of its statutory functions. There are quite a large number of providers here and nationally that may have been registered 2 or 3 years ago but have still not had their first inspection. And the CQC currently is managing only about 10% of the inspections that they used to do. However, there has been a complete change of leadership at the top of the Care Quality Commission nationally, a major shift in approach, and we are reassured that they will be working more effectively in the future. But in the meantime, we have a strong commercial team in the council which works very closely with providers to maintain quality. So to sort of summarise, if you have a Care Act eligible need for care in Lincolnshire, the council, we can place you. It is of sufficient quality. It's not of necessarily the quality that I would wish it to be, but it does meet the expected standard.
Thank you, Martin. No more questions? Thank you very much for the report, Martin. Agenda item 6, Adult Care and Public Health Scrutiny Committee Work Programme. As we work towards, as we look at this work programme, I'd encourage members to suggest any topics they feel we should cover. It's important that we get involved early so that the scrutiny can shape decisions rather than just respond to them. We have got a report from Simon Evans, Health Scrutiny Officer, who will present the report. Thank you, Simon.
Thank you, Chairman. For the benefit of new members, each scrutiny committee has an opportunity to review its work programme, usually the final item on each agenda. So there'll be one of these at each meeting during the course of the year and any other scrutiny committees during the course of the year. I know we are planning to have a discussion about populating some of the forthcoming meetings after the closure of this meeting, but I don't really want to go into any more detail on it, but I will take any questions that people wish to ask now. Thank you, Chairman.
Thank you, Simon. Have we got any questions for Simon? No questions. Well, thank you very much. I'm assuming that's it then. The meeting's closed. Thank you so much for attending. Thank you.